Top Med Talk.
Today's Top Med Talk is about the COVID-19 crisis. This piece was recorded last year. However, we still believe it contains lots of useful information. Have a listen.
Now, our next guests are joining us from the Penn Medicine Princeton Medical Center in New Jersey, a hotspot near one of the U.S. epicenters in New York City. Professor Michael Scott is a friend and a recent guest on Top Med Talk at the University of Pennsylvania. Mike, hello, how are you?
Very well, I'm glad to say, Desiree.
Now, Mike, you introduced us to Maurizio Serreta, who is a colleague of yours at UPenn, and he put us in contact with Mirko Nacotti, a physician for Bergamo, Italy, and talked about the devastated city there, the hardest hit area in Italy. That time you were working with prepping and planning. What are you doing these days?
I think what's interesting is people's approach to that podcast were almost disbelief that it wouldn't happen to us over here. And it was about 5 to 6 days later that people realized that New York was transitioning into the same sort of environment where they were seeing more and more cases. And of course, in the last week or so, where we now know they are surging outside of all their ICUs into the new COVID units and the PACU, and really struggling with staffing and resources. And so we're seeing the same pattern in cities throughout the USA now that we were seeing in Italy, Spain, and other countries in Europe.
Yeah. Now, Mike, you're usually working in Philadelphia at the University Hospital, but you're now in New Jersey. So tell me about how you've made that transition.
Part of the Penn Medicine health system is we've got other satellite hospitals at Lancaster, Chester County, and also here in New Jersey in Princeton. Obviously, with my role being Chief of Critical Care, along with Jack Gucci, who is the CMO of Critical Care here, we are responsible for the whole of critical care across all sites. And so we see that New Jersey, although it's slightly behind New York, is actually ahead of us in Philadelphia. So they were getting many more patients about 8 to 9 days sooner than we've seen in Philadelphia. And in just a few days, they've really surged past their normal critical care capacity and now into the PACU. This is no longer about providing the most evidence-based critical care medicine. This is really now resource mapping and staffing and actually teaching our staffing. We're all hoping that obviously it won't go to the enormous numbers that everyone's predicting, and hopefully the social isolation has really reduced the peak. But unfortunately, we are seeing the predictive curve here. This is all now about how do we train our staff so we can deliver the basic stuff.
Michael, I know that you're joined there in Princeton with some colleagues. Can you introduce who else is in the room with you?
Yes, so Ch.B, Bajaj, Head of Critical Care here. And I'll let Bridget introduce herself, who's the Chair of Anesthesiology.
Hi, Bridget Ruscito.
And I've got Jess with me, who is another anesthesia intensive care doctor from University of Pennsylvania in Philadelphia.
Hello, Jesse Kiefer.
Yeah, Ch.B Bajaj.
Thank you all for joining us. I would like to start with Ch.B. Can you tell us your title again?
So I'm the medical director of the critical care unit here at Princeton Medical Center.
Can you paint us a picture of what's happening there at your hospital?
During the past 2 weeks, this has really spawned upon us. Mm-hmm. We were concerned about cases we were hearing in the epicenter in New York City and wondering if it would ever make its way down here. We started to see cases pop up in this community and community just south of us. And we're right in the middle. And as I just said, over the past 2 weeks, we went from perhaps 3 or 4 suspected cases in the critical care unit to over 25 cases that have now been confirmed who are critically ill on full ventilator support.
Give us a picture of how many ICU beds did you have to begin with? What is your capacity to take care of these COVID patients in your critical care units themselves?
So our ICU in the scheme of things is relatively small. We have a 24-bed medical surgical ICU. We are a community medical center here. And we've been able to run this ICU with in-house 24/7 critical care presence. Our census in general has been ranging between 16 to perhaps 17 folks on an average 24-hour period. And now we're at a stage where we are beyond our ability to take care of even 24 patients. To the point where we've had to now create a COVID unit, which has now gone to the PACU, a brand new unit to help take care of these folks. There's been a lot of demand been placed on all of us as the intensivists here. Before we had one intensivist for every 12-hour period, and now we're finding that there are 3 intensivists that are present during the daytime, and even that is insufficient to be able to properly take care of these very, very sick folks who have multi-organ failures as part of their disease pattern, who require very complex ventilator strategies and require a lot of interventions throughout the day.
Yeah. What about your nursing staff? Is anybody out with COVID? I mean, that's for anyone, but...
Yeah, we've had a number of nurses who have been quarantined over the past 2 weeks. In fact, as I looked at our census today as to who is available in the nursing staff, our critical care nurses, out of the 17 nurses actually, who are there, only 5 of them are the critical care nurses who we are familiar with. So we've had to pull nurses from all over the hospital who perhaps don't have the same level of experience in managing these critically ill patients, who are not only taking care of them, but have a great amount of responsibility in doing things which they were not familiar with.
Let's stick with staffing. Bridget, I know, is the chair of the anesthesiology department there. Bridget, can you tell us about what's happening there with your department?
Yes. On Friday, we were looking at critical staffing issues with critical care, and we went from a department of about 30 anesthesiologists and 13 CRNAs on Friday to all getting emergency privileges in critical care on Saturday. And we have been all working incredibly hard to try to support the critical care clinicians in that effort.
And can you tell me what you're doing for education for your providers to go back into the unit?
We've been very fortunate to be part of the Penn health system, and Jesse and Mike have come out and provided a lot of very intensive focused education about specific management of COVID patients in intensive care. Initially, with the sudden surge in patients, we were very focused a lot on helping get these patients intubated on ventilators, getting central lines, arterial lines in. We really started helping in the ICU on Sunday, and I think we've intubated probably 25 of the 27 patients in the intensive care unit. The emergency room has intubated a couple of the patients, and then we've helped a lot with putting in at least 15 central lines and probably that many A lines as well.
Yeah. Oh my goodness. So have you done hospital-wide intubation teams, or going down to the ER or anything like that?
We're trying to do the intubations in a negative pressure area. So if a patient is on the floor, not in a negative pressure room, we are attempting to try to move them to the ICU where there is a negative pressure room. Same thing in the emergency room. If there's a negative pressure room available, we'll intubate there as long as the patient is stable.
Yeah.
Otherwise, we do it right where they are.
Had so many questions about what are people doing as far as a specific protocol for intubation. So can you just briefly touch on that?
We are doing rapid sequence inductions. We try to pre-oxygenate the patient as much as possible with the non-rebreathers. We are using glide scopes almost exclusively. That allows us good visualization. We're able to stand a little bit further away from the head. There's a lot of stuff on social media about different ways that people are doing things. We have tried the acrylic intubation boxes. We've had some success with that. People are also attempting to intubate under clear sheets just to prevent that additional aerosolization while we're taking care of the patient.
Mm-hmm. Are you giving propofol and succinylcholine? Are you using etomidate? What specific drugs are you using?
Reduced dose of propofol, so small doses of propofol, depending on the patient's size and age, anywhere from 50 to 100 milligrams, and then succinylcholine.
What type of response are you seeing with these patients' hemodynamics once you give that induction dose?
We've created some drug kits for intubating these patients, and part of our drug kit is a syringe of phenylephrine. Almost invariably, all of the patients are getting some phenylephrine right away. As soon as we go onto the ventilator and positive pressure ventilation, they do tend to drop their pressure. And as part of our teaching and education about COVID, these patients have been struggling to breathe. They haven't been drinking, so they have a fluid deficit as well.
Going back to Jazz and talking a little bit about the non-COVID units. Jazz, what are you and your team developing there? I know you said you're going into PACU. Do you anticipate that you may be even overflowing from that area?
Absolutely. We've had several phases thinking through this. So going from the critical care unit, which is being staffed by the intensivists, moving to the PACU, which really is now being staffed by the anesthesiologist taking care of these critically ill folks. The third phase that we're actually beginning to work on is cohorting patients At Princeton Medical Center, we have one patient per room traditionally, but we're now reaching a state where we feel cohorting becomes important. We're at max volume, or perhaps we have one bed left over for a code situation, but the team is now working on starting up as much as 8 beds that'll be available for cohorting purposes by the end of this week. So we would have the equipment ready, the IT support that we would need. Once we reach our limit there, we would have to start thinking about the next steps, especially as we fill up the PACU, which has the capability in our hospital of taking care of 14 patients right now. Luckily, we're being supported strongly by the healthcare system, Penn Medicine, without which support we would really be in bad shape as a community hospital right now. We're seeing a lot of shortages, not only in space, but certainly equipment. Ventilators are something that's been on the mind of all folks who are practicing critical care. And in anticipation, we were able to get additional ventilators provided by the Penn Medicine system. In fact, we're still facing some shortages, and we're being told that more ventilators are on the way. So there's some promising things here. But as the anticipated volume increases, I'm afraid that's going to be an ongoing issue.
Is there any move locally to open up out-of-hospital intensive care units?
Yeah, and from what I just heard, there is a center up in North Jersey, the Expo Center, which is being converted into a COVID center, essentially. They're asking for help from physicians, nurses, all sorts of personnel to assist. So that is happening, and that's closer to New York City. It is in New Jersey itself, but closer to the city.
Now, Jess, I know that education has been part of your mission in this time. So can you tell us a little bit about what you guys are doing as far as educating non-critical care staff to step into this role?
Yeah, so a lot of it initially started from how do we prepare our residents locally at Penn to manage these patients outside of if they're in the OR, manage them as an ICU patient. That's been extrapolated to training our kind of general anesthesiologists that as well. We've mentioned this idea of like high-level critical care, different ventilation strategies, proning patients. We're trying to just simplify that down and make sure we're not missing like the simple things we do in critical care.
Yeah.
Standardizing daily rounds for the patients, making sure they're being woken up when they can be, making sure they're appropriately sedated, making sure they're getting nutrition when they should be and not being fed, because we know that can delay kind of extubation, delay progression. Making sure we're avoiding secondary infections, skin breakdown wound, have appropriate prophylaxis, GI prophylaxis, DVT prophylaxis. So sometimes the things that aren't often thought about, but can actually have a fairly large impact on our patients. So we've taken that, have PowerPoints we've given to the Princeton Anesthesiology group, seen it pretty well received. We've shared with our residents, shared with our faculty. And then we're also moving into how do we set up documentation? How do we have if you use an electronic record, we know the OR screen is very different than the ICU screen.
Yes.
So we've had some of our advanced practice providers come as well and work with the anesthesia group and show this is how you set up a lab list. How do you put orders in? Kind of those practical things you don't have to think about.
Yeah.
And I think we're going to see that being hopefully not missed as we move forward. And this can serve as an example of what can be done. Yeah. We've also just made some really simple placards of like, this is how you could use an OR ventilator as an ICU ventilator, how you could check a plateau pressure on that, what you should consider for your fresh gas flows, generalized COVID management, as well as some simple point-of-care ultrasound techniques, whether it's looking at lung ultrasound or kind of IVC assessment, fluid management, which we know early on these patients, they might be volume deplete. But as the disease progresses, they're probably to end up being on the drier side. So how do you inform that decision? So we're really trying to build those resources so that we could all share them as a health system and hopefully potentially even share outside of our system. And it can serve as an example of what works.
Jez, can you speak a little bit to managing ventilations for these COVID patients? Are there any pitfalls or anything that we're seeing, or is it basically really traditional ARDS?
So yes, you're absolutely right. The management strategies that we've been using on these folks, because we see a classic pattern of ARDS earlier on in their disease as they progress quite rapidly. They presented to us with, as everyone's described, shortness of breath, fatigue, myalgias, poor appetite. I've even seen cases with loss of taste as kind of the earlier presentations, which has been reported in the literature. And they're admitted often to the regular medical floors where they're being monitored very carefully. And within 24 hours, within 30 hours, we're finding they go from perhaps a couple of liters of supplemental oxygen, nasal cannula, to venti mask and rapidly thereafter to a non-rebreather face mask along with supplemental yet nasal cannula at high liters per minute. They become quite dyspneic, out of breath, in respiratory distress. And the strategy that we've taken here is to try and intubate people. I know there's been a discussion going back and forth. What do we do with these folks? Do we try to support them using non-invasive methods initially and wait to see perhaps who may stabilize versus just early intubation? And in my mind, the strategy that I feel that is necessary is early intubation and stabilizing these patients before they develop further organ failures. And as we receive them in the ICU, we see that they're requiring very high FiO2, and we find that their PF ratio is quite low. In fact, most of the time we're seeing that ratio well below 100, 60, 80. And the strategy that we've been using is a low stress strategy, the NIH ARTSNet strategy, trying to maintain low volume, starting at 6 milliliters per kilogram of predicted body weight, and trying to maintain plateau pressures below 30. Mm-hmm. We're finding that as we measure their initial plateau pressures very frequently, they aren't very high. We're finding that they're, in fact, in the low 20s most of the time. The average FiO2, in fact, when we're starting out and trying to make decisions as to kind of what the next strategies might be, the FiO2 very frequently, we have to use 100%. Mm-hmm. And we've been trying to go up on the PEEP, gradually following the ARTSNet FiO2 to PEEP table as much as we can, watching very carefully for hypotension development, because again, we are dealing with lungs initially that are not perhaps as stiff. Perhaps
that's what I was just going to say, yeah.
Yeah, more compliant lungs, and we're very careful in following that precisely because, again, these lungs are not very classically stiff that one sees in ARDS. So you have to be very careful in that. We're finding that within about 24 hours after we optimize our ventilator strategies using the NIH approach, that our PF ratios remain quite low. And we have adapted the ProSiva trial, the early proning, where if the PF ratio remains below 150, within 24 hours to 36 hours, we are proning these folks early. And we find that's where the key is going to be. We've had a lot of help from our anesthesiology colleagues and other healthcare providers, nurses, physician extenders in helping us prone these folks, without which it would not be possible to prone now at least 8 to 10 people in the ICU that are prone.
How were you prepared to prone patients? Because I mean, not that it hasn't necessarily fallen out of favor, but I know a lot of people don't have 10, 15 prone beds in their ICUs.
No, we do it the old-fashioned way. We turn people over, get a whole bunch of people together, nurses, RTs, physicians, and we just do it the old-fashioned way. Wow. We've been doing this for many years here, so we are used to that. Okay. However, the volume that we have right now, perhaps in the past, we would see 1 or 2 patients a month. Who would we be proning? Now we're proning 10 people a day, and so we really need a lot of support and structure. We're utilizing a lot of drugs, and we're seeing a lot of shortages. Not only sedatives, we're seeing massive shortages, but we're seeing shortages in our traditionally used paralytic agents. For example, cisatracurium is at a shortage nationwide. So we're adopting other ways to paralyze these patients. We find a lot of patient ventilator dysynchrony, and we're having to use vecuronium. And I'm finding more recently, as I was told last evening, that now there's a shortage of vecuronium. Yeah, and I'm being told to perhaps think about using rocuronium. So we're really facing a lot of challenges in that regard. So not only space, equipment, but also drug shortages.
Yes. Yes. And is that the typical course that patients would be receiving, a paralytic infusion and as well as a sedative during that?
Yes. In the initial phases, just to better synchronize folks as we're managing them, trying to prevent this volutrauma, barotrauma from occurring and perhaps leading to further biotrauma and other organ failures, I think it's important to really get a good control on the mechanics of ventilation early on.
And then you were speaking a little bit to the difficulty in managing the hemodynamics for these patients, just because they do usually come in a little bit dry. Some people saying that we should be on the line of keeping them dry. What are you seeing as far as hemodynamic management and how you are managing them?
As we intubate these folks, especially as Bridget was pointing out, and Mike has been educating folks on, is that they're intravascularly depleted, that their preloads are low. So as we intubate these patients, we find very commonly that their blood pressure drops, We're finding that even if, we're doing bedside assessments using ultrasound assessments or their IVC, certainly it's consistent with low volumes, and these patients are volume responsive in the initial phases. So one has to be very careful there. We're finding a lot of folks are requiring vasopressors up front as we resuscitate them, and then we're able to actually taper them down shortly thereafter in many cases. Cases where, this has gone to the level of multi-organ failure, of course, we're still using vasopressors on these agents, but in general, we're finding that they're preload dependent, that they're volume responsive.
Have you had anyone that you are extubating and that are recovering? And what does that picture look like? Because I know we've had a ton of questions about that.
We've had near cases where we've seen suddenly patients start to improve. Within 3 days of ventilator support, their FiO2 start to come down. We're being very careful in terms of tapering PEEP. We know that these guys can become de-recruited quite easily. However, in those few cases that I'm thinking about right now, within 36 hours later, we're finding that all of a sudden they have almost a cytokine storm effect. Their FiO2 requirements start to go back up. Their lungs are becoming more stiff. And for the past week or so, or 10 days when it's really taken off, so far we've not had any patients come off the ventilator. We're supporting a lot of these folks. We have some folks who are older folks with a lot of comorbidities who have just not responded to any therapies. And certainly we've been doing our best to kind of help them through various phases, including moving on to comfort measures in some of those folks.
I think that's the same message we're getting from everywhere, which is a little bit disappointing in one way. Is it's not quick. When you're under tremendous bed pressures, you're kind of hoping it's 5 or 6 days. Yeah. Whip the tube out, but everyone says that there's quite often stormy course after extubation. Reintubation is not unusual, and it's a waiting game, which is difficult when you don't have a lot of beds.
Yes, absolutely. And these folks, some of them are relatively young. We're seeing, on the other hand, folks that are in their 50s, even 40s, but 50s without many comorbidities or without any comorbidities. And that's the part where it becomes really, really emotionally draining to try to figure out how to deal with this.
Now, Mike, I wanted to ask you telemedicine and how you're utilizing the provider in a remote location, but being able to provide care remotely. So can you walk us through that a little bit and how you're translating that now into the types of patients and the units that you're working in?
Yeah, so we've got a very big connected telehealth medicine unit at Penn Medicine, which does calls from the general public. And we also have 330 monitored beds in all the ICUs across 3 of our main hospitals, all going to a centre down at Rittenhouse in Philadelphia. And I'm medical director of that, and Anne Huffenberger is the actual director of the whole place. And this has been a very interesting time because it's put huge pressures on us, but at the same time there's enormous opportunity. So the basic setup is we have a camera in every room that can zoom up to 20 times. You can go and look at the monitors, and the monitors are passed through anyway, but you can look at the pumps, you can look at the ventilator. Mm-hmm. And we have nurses remotely and physicians. So we have pass-through alarms and routine things that we'll do. We have an ARDS program which triggers us to look at the vents, and we can help staff normally. What's different with this is that we've actually opened the cameras to all our staff, and now a lot of people are using the cameras to do a lot of the day-to-day jobs that they do from the local ICU desk. And what that has done is reduce the amount of times people go in and out of the room enormously, and the amount of PPE that's used. And one group that's really benefited from this is the respiratory therapists, and they can do a lot of their work remotely now. And that's been really beneficial in a group that otherwise have a high exposure risk. Okay. And then we've actually building up our system to having even more people on the service. We've got residents and APPs and more attendings, particularly those that have got medical conditions that put them at risk in the front line. And then the other thing we've done, like here at Princeton, where there weren't the cameras, is we've got a mobile cart up in the PACU, the new area, and then we're putting iPads and creating a new system of telemedicine using an iPad in every ICU room. And this we're trying to transition and grow around the whole health system at the moment.
Mike, if you had to choose between the pass-through monitor and the camera, which do you think is the most valuable?
That's a difficult one because there's two ways you can use telemedicine. You can do it proactively or reactively. So it's traditionally been a bit of a reactive system where you're sitting in your room remotely, got all the monitors up there. You've got effectively a scoring system to see the patients at risk. And you can use the camera, and you've got your Epic chart, basically, so that you can go in and do orders and change things and support the staff. But we're finding that proactive rounding is very effective in the current crises because of the staff limitations. And we're trying to slant the whole of our delivery more to evening, early nights, because in the mornings we've got a lot of staff everywhere, but it's the evenings where a re-round virtually really helps. And the system's very powerful. We've even got attendings who've done virtual rounding from home just as a trial, just to see if it can work. Has really demonstrated the value of having cameras and setups in the patient rooms. The challenge is the new COVID units, because we've not got those cameras, so we're having to use the iPads. And
is the camera the big added value there, Mike? Because being able to
yes.
remote, so I was thinking, because we should be able to work out how to retrofit those fairly quickly, shouldn't we?
Yeah, I mean, we've looked at everything from getting other proprietary branded, security cameras that are wireless. But there's an enormous lack of these equipment out there at the moment because everyone's wanting this at the same time.
Yeah.
Are you having trouble with bandwidth? I mean, are the hospitals equipped to deal with that? Because I can see people wanting to do that. And I know in some of the hospitals where I've been, bandwidth has always been the issue for transmitting like an iPad from, room to desk kind of thing.
I don't want to tempt fate, really. But so far, we are okay. We have a fantastic IS information services department who are supporting us. And they are, as you say, trying to basically liberate bandwidth for us.
You were telling me earlier about an alert system that you have that everyone there is able to use the pennies. Can you talk to us about that a little bit?
Well, it's just something that we're piloting here. It's basically like disaster triage. And we're trying to, because what we're really faced with is if we turn up at the start of every day, you've got a very different skill mix, as Jas was saying. And so there's no point putting someone who is already acting beyond their normal scope of practice into, say, a patient who's got unstable ARDS. So what we've tried to do is use the traffic light system to classify patients. So green is they're getting better and they're being downgraded. Yellow is they've got COVID but they're on oxygen. Orange is they're stable and ventilated and they're sort of flying at a level altitude. Whereas red is they've had some sort of decompensation in the last 12 hours. So they really need quite a close look at. And then we've got purple if you've reached the ceiling of care and you've got to think about whether you've got to get the palliative team involved. And the idea is to try and build this system on the Epic platform so that we can have visibility of the way we can see all our COVID patients and at what state they are. And then at the beginning of every day, we can put the appropriate task force to each set of patients. Because we're seeing very mixed units at the moment, because ultimately the COVID patients are just being cohorted.
So if there's one major learning point from, specifically for you, Bridget, for anesthesia, about what we should take away if we haven't seen patients yet, what would that be for you?
Just having to manage supply issues. We've had to bring our anesthesia machines into the recovery room, PACU, and that's what we are using to ventilate some of our patients with as we wait for more ventilators to come in. It's very different to ventilate a patient for a couple of hours for an anesthetic versus more of a longer term picture. Just having to know about how to adjust flows, filters that are important, changing. It's just a lot of different learning that we've had to do. So that's something that other people will probably need to look out for as it comes towards them too.
Yeah, and I guess you're still having to cover the OR cases too. Are you doing many emergent cases down there?
We're only doing emergency cases now, really urgent cases. We are still covering obstetrics, and we've actually had, we've seen an increase in volume. I think patients coming from North Jersey, maybe even New York City, are delivering here. We're doing a lot of obstetrics. We already had a decent volume anyway, but we're seeing more of that. We are doing a lot of OR, OB anesthesia too as well.
Oh, wow. So I'm sure that's a challenge. All right. Well, thank you so much, Bridget, for everything that you're doing. We appreciate you, and for sure. So, Jazz, is there anything, a learning point for you that for those of us who are getting ready to face a surge of our own, what would be the number one thing that we should focus on?
I think using protocols, using a structured method of doing things, standardized methods in all comers, and perhaps even using non-traditional people who perhaps are not trained to perform critical care, physician extenders, to help maintain that order and help maintain a certain structure of flow. All the things as Jess was referring to, leveraging that workforce is going to be very helpful.
Yeah. All right. Well, thank you for everything that you're doing. I hope as you guys there are in the trenches, you and Bridget and the rest of your teams, and I hope you guys are hanging in there and taking care of yourselves as much as you can.
Thank you. Thank you.
Jess and Mike, any final thoughts for you guys?
No, I think Jazz hit kind of my sentiment as well. I think this really shows how, as a critical care anesthesiologist, how closely two specialties are tied. Mm-hmm. I think it provides a unique opportunity for the United States anesthesiologists and our CRNAs and our residents, our trainees to step outside our comfort zone. It's such a natural extension of our practice, and the use of protocols and just standardization really allows us to take a really active footprint in this crisis.
Yeah, absolutely. And I just want to say thank you to you for, putting these educational programs and things like that together and sharing that knowledge. It's going to be an integral part to managing through this. So thank you.
I think really it's just been the most amazing response from medical and all health providers around the globe at the moment. I think people in their lifetime will look back for these few months and everyone's going to remember them.
Mm-hmm. Absolutely. Well, everyone there, thank you so much. Monty, thank you for joining this conversation. To all of our listeners, please stay safe, take care of yourself, and we're going to make it through it. It's going to be tough. I think that there are going to be a lot of ideas and new things that are going to be born out of this, but know that we're all behind you here on Top Med Talk, and we look forward to speaking with you soon. So thank you guys so much, and we will talk to you later. Stay safe.
Top Med Talk.
Thank you for listening to Top Med Talk. You know you can always find us on Twitter, LinkedIn, Facebook, and on topmedtalk.com. We want everyone to stay safe. If you have any questions or you want to talk to us on Top Med Talk, please reach out via contact@topmedtalk.com. That's contact@topmedtalk. Thanks for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.